So what are the sympatholytic drugs? These are drugs so they can block alpha receptors, they can block beta receptors, or they can combinedly block the beta and the alpha receptors. So first of all, we're going to talk about the alpha blockers. In that we have the non-selective blockers, phenoxybenzamine. This is an irreversible antagonist, and phentolamine and tolazine, they are the reversible antagonists of alpha-1 and alpha-2 receptors. The basic characteristic feature is vasodilatation, and also they cause postural hypotension. Postural hypotension is due to the vasoconstrictor alpha-1 receptors. There is a reflex increase in the sympathetic discharge and increase in the sympathetic outflow, and that is due to the blockade of the alpha-2 receptors. And this may lead to marked tachycardia that is seen with the use of these agents. If we use these drugs before adrenaline, that may cause vasomotor reversal of day. In normal conditions, what happens if we give intravenous injection of adrenaline, then there is an increase in blood pressure, that is the alpha effect, and that is followed by a fall in blood pressure, that is the beta 2 effect. But if we after giving the alpha blockers, we give intravenous injection of adrenaline, then only the fall in blood pressure is seen, and that phenomena is known as the vasomotor reversal of Dale. Next, let's get to know more about these drugs. Phenoxybenzamine is used to prevent hypertensive episodes during the operative treatment in pheochromocytoma, that is the adrenal gland tumor. Phentolamine and tolazolene, they are also used for the treatment of hypertension during some phenomena like clonidine withdrawal reactions and cheese reactions. Next, that's all about non-selective alpha blockers. Let's talk about the selective alpha-1 blockers. The selective alpha-1 blockers are prazosin, terazosin, doxazosine, alfuzosin. They cause a decrease in the blood pressure with less tachycardia as compared to the non-selective blockers. Why? There is a lack of alpha-2 blocking action, and the sympathetic outflow is also not increased. Other favorable effects, they have a favorable effect on the lipid profile. HDL is increased, that is a good cholesterol. Bad cholesterol like LDL and triglycerides, they are decreased. Then there is a relaxation of the smooth muscles in the neck of urinary bladder and prostatic urethra. That increases the urinary flow. And selective alpha-1 blockers, they are the drug of choice for people suffering from benign hyperplasia of prostate combined with hypertension. Now, alpha receptors, they are a very importantly playing role in the pathogenesis of heart failure and also pulmonary edema that may occur due to scorpion bite or scorpion sting. So what is the drug of choice for scorpion sting? Prazosin. Then let's talk about the adverse effects. The major adverse effects of these selective alpha-1 blockers is the postural hypotension that may occur with the first few doses, and that is why it is also known as the first dose effect. If we continuously use these drugs, tolerance develops to this first dose effect, and later on it is not seen. Another is the inhibition of ejaculation in the males. That is another side effect of these drugs. Let's talk about more drugs. Tamsulosin, salodosine, they selectively inhibit the subtype of alpha-1 receptors present in the prostate. And what is this subtype? Alpha-1A. They don't affect the alpha receptors that are present in the blood vessels. So they are specifically, very, very specifically acting on alpha-1A. And they are preferred for the treatment of benign hyperplasia of prostate. And they cause very less postural hypotension. So another side effect that has been seen is the floppy iris syndrome. That is the intraoperative side effect during the cataract surgery that has been observed with this drug, tamsulosin. Next, let's talk about more drugs. Indoramine, uripidil. They are very occasionally used for hypertensive emergencies. Not very common drugs, very rare drugs, and they find very rare use. Let's talk about selective alpha-2 blockers. Yohimbine, irazoxan. Yohimbine and irazoxan, they are the blockers of alpha-2 receptors, but their clinical use is almost negligible. They are not used clinically at all. So, without any delay, let's jump over to beta blockers. First of all, in this also, we will talk about the non-selective, that is the first generation beta blockers. The drugs are propranolol, timolol, nadolol, pindolol, alpranolol, and oxpranolol. What are the important effects of these drugs? they decrease the myocardial oxygen demand. And why does they do so? They block the beta-1 receptors in the heart. So they're very useful in the treatment of classical angina. And coronary vasoconstriction can occur due to the blockade of vasodilatory beta-2 receptors. And that is why they are useful in classical angina, but they are totally contraindicated in variant angina. Just mark my words, they are totally contraindicated in variant angina. Let's move further. Decrease in the blood pressure occurs, that is due to the beta-1 blockade. Bronchoconstriction occurs due to the beta-2 receptor blockade in the lungs. And that is why they are contraindicated in the asthmatics also. Again, mark my words, they are contraindicated in the asthmatics also. So what are the limitations? We have many limitations of non-selective beta blockers. Contraindicated in bronchial asthma, because they are causing bronchoconstriction. Hypoglycemia is very nicely observed in diabetic patients which receive insulin and oral hypoglycemic drugs. Sometimes the symptoms of the hypoglycemia like tachycardia, sweating, tremors, they are also the warning signs. They are masked in these patients due to the use of these non-selective beta blockers. That is a very dangerous situation. Beta blockers can mask these symptoms but not sweating. Only sweating occurs, which is not masked, and the patient can directly go into coma. That is a very dangerous situation. Further, they delay the recovery from hypoglycemia due to inhibition of the beta-2 mediated hyperglycemia. So, these drugs are totally contraindicated in diabetic patients also. These are the limitations of non-selective beta blockers. If you use beta blockers, non-selective ones, on a long-term basis, they can adversely affect the lipid profile and they can cause glucose intolerance. Now, they cause bronchoconstriction, they cause vasoconstriction because of beta-2 is vasodilatory and they block the beta-2 receptors. So by causing the vasoconstriction, they can worsen the peripheral vascular diseases also, and they are contraindicated in the Raynaud's disease or Raynaud's phenomena. Then another problem with non-selective beta blockers, they can impair the exercise capacity. Why? They block the skeletal vascular beta-2 receptors. That is how they impair the exercise capacity. Now we have so many problems with non-selective beta blockers. What to do? Let's jump over to the selective ones. First of all, we have second generation drugs. Second generation beta blockers, that is the cardioselective beta blockers. Now, these are preferred in the patients with diabetes mellitus, bronchial asthma, peripheral vascular disease like Raynaud's phenomena and hyperlipidemia. All the problems can be circumpassed and surpassed by using these second generation selective cardioselective beta blockers. What are the drugs? Nebivolol. Nebivolol is the most cardioselective agent. Other drugs are betaxolol, bisoprolol, acebutolol, esmolol, atenolol, metoprolol, and celiprolol. Then what are the advantages of these cardioselective beta blockers? They are very safe in asthma, in diabetes, in peripheral vascular diseases. They do not impair the exercise capacity. There is less risk of hyperglycemia, and there is a less risk of dyslipidemia also. Now we have another topic, the beta blockers with intrinsic sympathomimetic activity, that is capital ISA. Now what are these drugs? Let's get to know these drugs. These are the partial agonists at beta-1 receptors, and they also have beta blocking properties, but they are partial agonists at beta-1 receptors, and they are preferred in patients which can develop very severe bradycardia with beta blocker therapy. But they are have limited use in angina. They are not very useful in angina, and they can also cause stimulation of heart by causing stimulation of the beta-1 receptors. And what are these drugs? These drugs are pindolol, penbutalol, alpranolol, acebutolol, celiprolol, oxprenolol. Next group of drugs, beta blockers having membrane stabilizing activity. What are these drugs? What is their action? They have a sodium channel blocking action. That is also a local anesthetic action, and they can contribute to anti-arrhythmic action. And these drugs should be totally avoided in glaucoma. They can cause corneal anesthesia. What are these drugs? propranolol, that is has the maximum membrane stabilizing activity. Other drugs are metoprolol, labetalol, acebutolol, pindolol. Now we have another group of drugs, the beta blockers, which are lipid insoluble. And what is the characteristic of these drugs? They are excreted by kidney and they are contraindicated in the renal failure. They have a very long duration of action. And what are these drugs? The longest acting beta blocker is nadolol. Other drugs in this group are sotalol, atenolol, acebutolol, betaxolol, bisoprolol, celiprolol. Now, apart from these drugs, the other beta blockers, they are metabolized by liver, excreted by liver, and they are short acting. And what is the shortest acting? Esmolol. Now, one important note point, acebutolol has all the activities. It is cardioselective also, it has intrinsic sympathomimetic activity also, it has membrane stabilizing activity also, and it is lipid insoluble also. So this is a characteristic feature of acebutolol. Let's come to the next group of drugs, third generation beta blockers. They have additional vasodilatory property, and these can be due to different mechanisms. First mechanism is alpha blockade. The drugs are labetalol, carvedilol. The second mechanism is beta-2 agonism. The drugs are celiprolol, cartiolol, bopindolol. The third mechanism is release of nitric oxide. The drugs are nebivolol and nipradolol. Then the next mechanism is by the opening of the potassium channels. The drug is talisolol. And the last mechanism is inhibition of the calcium channels, and the drug is carvedilol, bevantolol, betaxolol. So these by different all are causing one single action, that is additional vasodilatory action. Now, what are the common uses of beta blockers? There can be two types of uses. We can just make tables. They can be cardiac uses. They can be non-cardiac uses. Coming over to the cardiac uses, they are very useful due to beta-1 blockade in hypertension, classical angina, myocardial infarction, supraventricular arrhythmias, chronic CHF, hypertrophic obstructive cardiomyopathy. They are the drug of choice actually. And other things they are helpful is mitral valve prolapse, emergency management of the symptoms of TOF. Then what are the extracardiac uses due to beta-2 blockade activity? Hyperthyroidism, performance anxiety, pheochromocytoma, tremors, akathisia, prophylaxis of migraine, glaucoma. What drugs are useful in glaucoma? Timolol and betaxolol. And they are also useful in alcohol opioid withdrawal and prophylaxis of the bleeding in portal hypertension. That's the major chunk part of the beta blockers. Let's go for the ending part. Let's talk about combined alpha and beta blockers. What are the drugs? Labetalol and carvedilol. They are the important drugs in this group. They can control the hypertension, especially in pheochromocytoma. And carvedilol is the most commonly used beta blocker in chronic CHF also. Why? Because it has antioxidant properties. It has anti-mitogenic properties. And other drugs having alpha and beta combined blocking actions, they are medraxolol and bucindolol. One important point about carvedilol, it is very highly bound to plasma protein, and the least bound to plasma protein is celiprolol. With this, we finish the sympatholytic agents. Next, whenever I get time, before I start the normal course of IS Pharmacology Difficult episodes, I would like to cover one more episode, very short one, that is glaucoma. I'll see when the time allows. Till then, till the next time, thank you, take care, bye-bye.